If I come back to Rinchus, Rinchus said here in this paper that canine protected occlusion is dangerous. And probably it is dangerous for the, I think that it is dangerous for the dentist, not for the patient. And, and it is a too provocative paper. Another paper from Ambra Michelotti, which is a very good person and researcher. But there's something wrong sometimes on his on hair terminology. I know very well Ambra, and so I can discuss this directly with her. She published in a paper concerning experimental interference. And it is the title of the paper, experimental interference. And what is the interference created by Ambra? It is a composite bonding here using separators like this, which create not occlusal interference. This is created an over-occlusion. And over-occlusion is different from interference. We have to define very precisely what is occlusal interference. Because over-occlusion is an anomaly of the stability. Interference are anomaly of movement. Stability is static. Interference is cinematic. Another confusion in a paper, 2018, not very old. This paper described a patient and say he had bilateral group function with working interference contact on all posterior teeth. It is very confused language. And science does not like confusion. It is the same in the glossary of prosthodontic. Occlusal interference, any tooth contact that inhibits the remaining occluding surface from achieving stable harmonious contact. For me, it is not interference, it is over occlusion, this. It is also the bouillabaisse. And it is a pity, because for many, many years, the definition of interference are very clear. In 1961, Ramfjord wrote, interference is a contact, only one on the non-functional side, preventing contact on the functional side. It is the first approach of definition of occlusion. That means no contact on the working side during a lateral movement. Some years after, Posselt, an interference is a non-working posterior occlusal interference with the left lateral protrusion, okay, Only contact on the last molars. Only contact here. The patient is realize the lateral movement on the left side. Only contact here. No contact on the working side. And it is non-working posterior occlusal interference. I agree. That means if you have a contact here in the same time of a posterior contact, it is not an interference. It is a balanced occlusion. That means balanced occlusion and interference are so different. And it was wrote in 1968 in a very famous book of occlusion. It is not in a secret publication. More than 50 years ago. In 1972, Ingervall from Sweden explained very simply the definition of occlusal interference, posterior occlusal interference. It is a posterior tooth disoccluded the anterior teeth in a translational movement. That means protrusion or lateral protrusion, not closing movement. Forward movement, lateral movement. It is a posterior tooth, posterior teeth, sorry, here, with disocclusion on all the teeth, especially the anterior teeth. That is a good definition for posterior occlusal interference. Look at this case. On the pictures on the upper part of the screen, it is ICP. Lateral view and frontal view. The patient realizes lateral protrusion, left lateral protrusion. We have a contact here without contact on the anterior teeth. In translation is in my knowledge is horizontal movement, protrusion and lateral protrusion. Posterior occlusal interference is a posterior occlusal contact disoccluding other teeth, especially the anterior. It is the same for working posterior occlusal interference. The patient realizes a movement, lateral protrusion on the right side, and after he came back from excursion to ICP, and there is only contact here. No anterior contact. It is a posterior occlusal interference. If you have in the same time contact on the canine and on the posterior teeth, it is not an interference. It is the same here. The contact is on the first premolar here. No contact with the canine. And if you know this type of definition, after and only after you can discuss concerning abstraction, recession, period recession, and so on. Posterior occlusal contact without simultaneous anterior contact. In Gerval, it was in 1972. 70, 42, 92, to, it is 50 years ago. And this type of definition is generally ignored by the, the dentist and some researchers. Not all, but some. So the guiding lateral occlusion must be classified with canine guidance. The canine disocclude all the teeth. Simultaneous contact between canine and a posterior teeth. Group function, where the canine with premolar and sometimes molar, and posterior interference, only posterior contact. So it is the situation for the posterior, for the, sorry, posterior interference. But there are not only posterior occlusal interference, there are also anterior occlusal interference. And an anterior occlusal interference is a locking guiding function. Locking guiding function. No overjet, no functional space. And the typical sign of this situation is to have friction contact during protrusive movement, for example here, on the buccal face of the mandibular incisors or canine. Normally, in the protrusion movement, it is the edge of the mandibular incisor which is moving along the lingual face of the upper incisors. It is one point, mandibular point, and a draw on the lingual face of the maxillary teeth. When you are in dysfunction, anterior dysfunction, the functioning is like this. The point is maxillary, and the draw is on the lower teeth. It's okay? Can I ask a question or comment? So we can separate different situations from the functional guidance. Functional guidance is here. When you have posterior occlusal interference, like this, it is a functional guidance. The anterior guidance is not functioning because excessive overjet or um, open bite. If we have an anterior locking or insufficient overjet, you have anterior occlusal interference, and so it is a dysfunctional guidance. So the guidance can be afunctional or dysfunctional. Functional, afunctional, or dysfunctional. Now I go to the intrusive control, and I had questions concerning this point. ICP, from a lingual view, you have the mandibular canine, which is in contact on this distal part to the first premolar, maxillary first premolar in ICP. In a centric position, the mandible is a little bit going backward, and the canine, mandibular canine, is going back here with a contact on the lingual cusp of the first maxillary premolar. And the way between ICP, which is here, and RCP, contact in centriculation, which is here, this way is a retrusive control. And this contact, because generally all the people are a difference between RCP and ICP. There's contact in RCP somewhere. The ideal position of the contact in RCP is on the first premolar, on this cusp here. Because it is the more anterior possible. So that means the more proprioceptive and the less overloading by muscle. More the teeth are anterior, more there are proprioception, and less there are forces. So the ideal situation for the retrusive control is on the first premolar. Another fact is that this cusp, this lingual cusp of the first premolar, is little bit rotated in the mesial direction. The teeth is not symmetric. It is asymmetric, and the lingual cusp is oriented to the mesial part. So it is ideally located, but perhaps we can have only one first contact on one side. It's enough for the mandible to have information, proprioceptive information, avoiding this contact during the closing movement, and go directly to ICP. If you have the contact on the both sides, it is an ideal situation, but it is not necessary to have the both on right and left side. And sometimes, if you have a contact on the second premolar, the RCP contact, it could work also. because the teeth is not really posterior, the proprioception is not so bad. So in retrusive control, you can have first only one contact, and sometimes you can accept contact on the second premolar. I have no evidence for this. It is opinions at this moment. But, and it is also opinions, probably prematurity on the molars, so contact in centric relation only on the molars is a critic situation because proprioception is not very good and forces are strong. And so when you have a posterior prematurity like here, the patient is in centric relation, the first contact is here, it is a critic situation. The same like here. And frequently is because supra-eruption of posterior teeth. For me, it is an obvious occlusal prematurity. And the obvious occlusal prematurity for me must be corrected first because there are no risks. Occlusal functions are delimit an envelope of movements in all the direction, anteriorly and coming back, protrusion laterally and coming back, and posteriorly and coming back in 3 directions. That means in all horizontal direction. You control the access to ICP with a maximum of proprioception. And it is lighted by the guiding arch, the green arch. If I summarize the guiding disorders, which call interference globally, we can have a special type of interference which is a premature contact, prematurity or premature contact in terminal axis movement in centric relation. It is an interference in the closing movement, in the vertical movement. The other concern the horizontal movement. You have the posterior occlusal interference in protrusion, here. You have the non-working posterior occlusal interference in lateral protrusion, like here. And sometimes there are some things to look on perio. Posterior contact, no anterior contact on anterior teeth. You can have working posterior contact, like here, contact on the molar, no contact on the canine. And after you have anterior occlusal interference, like here, It is a locking situation. And you have also some patient with a big anterior open bite, and you have here occlusal interference in all the directions. Okay, so I described occlusal functions and occlusal dysfunction. My objective is to classify, and classification is science. And the objective of this type of classification is to be able to observe some specific type of dysfunction, occlusal dysfunction, and not put everything in the same pot. When you know every type of occlusal dysfunction, you can be able to 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 make a research in occlusion. And from my point of view, if you don't know really the different type of occlusal dysfunction individually, you cannot be able to make research concerning occlusion. To make research concerning occlusion, first you have to know occlusion. And I close this first part by an invitation. In 2002, I hope the situation was quiet in the world from a sanitary point of view, and we will organize a big meeting on occlusion in Marseille. So it could be an opportunity for you to test the bouillabaisse. I hope so that you could participate. We can make some minutes for questions about this point. Yes. So there is a remark concerning RCP and ARP reference position. On my slides, sometimes I wrote ARP and sometimes I wrote RCP. It is the same. Good remark. I would like to have some comments about the classification of occlusion. Is it confused? Is it more clear? What are the points which stays confused? I have no comments. Okay. Concerning the questions, I have a question for the organization team. The question, the participant can read the questions like me or only me? Is it because I would like to know if I have to read the questions for all the participants. And there is a question to do you use cephalometric analysis? Okay, you everybody can see the questions. Perfect. So concerning the cephalometric analysis about vertical dimension, for example, yes, I use it. I will to explain this this afternoon. It's the same for the Wilson curve and curve of speed, but it's better to read them. Okay. Okay. And the question: do you calculate Wilson curve and curve of speed? Yes. Okay. So I don't want to discuss just now this point this afternoon. If you look there, the list of topic, you can see here occlusal plane. You can see here vertical dimension. And there is a question, interesting question concerning interference, anterior interference, occlusal interference. In case of locked function, do we need to correct interferences or angle by the means of orthodontic treatment? It's very interesting because if you have a patient with A function, if I go here, when we have posterior interference, frequently you can correct it by grinding, occlusal equilibration, or occlusal adjustment. But if you have this situation, sorry, uh, if you have this situation of locking, you cannot treat this situation by occlusal adjustment, grinding. Sometimes, if the teeth are in a bad health, you can make a prosthetic treatment, but the right way is orthodontic treatment. I hope to answer correctly to the question. Okay, think about 2 or 3 more questions, and I have to check. I must leave for 30 seconds. I have to check something, and I come back quickly. Okay, sorry for the interruption. I need to take something for my um, to be able to speak because I got a cold. Okay, no questions? Okay, good questions concerning the interference. There are more risky situations. It is opinions. No very strong evidence for this, but probably there are big consensus to say non-working posterior occlusal interference are more risky than working posterior interference because the forces and the amplitude of the movement is more important. Concerning the anterior interference, there are probably a difference between the incisor locking and canine locking. And in some case of class 2 with anterior incisor guidance, the canine must be open. And for the patient, he is limited in protrusive movement, but it is not limited in lateral occlusion. So it is probably not a strong risky situation for the TMG because he can go in different movement. And on Tuesday evening, we'll discuss the importance of the capacity of movement for the TMG, for the health of the TMG. Okay, I hope answered correctly to the questions. Another one? Okay, so we go.